I was saying that in general, I tend to be enthusiastic about the new era that oncology has entered. The reason being that the new treatment modalities, including targeted agents as well as immuno-oncology, has made a seismic shift in oncology, making it possible to have hopes even for the most difficult part of a portion of our patient, that is those patients with disseminated disease, leaving them hopes for very long term survival and sometimes cure. And this is also true in the GI arena, where in general advancements have not been so impressive as in non-small cell lung cancer, say, for example, or GU or GYN type of cancers, not to mention melanoma. Unfortunately, the only area in GI oncology where these next to miracle type of advancements have been made is pancreatic cancer. That continues to be a tremendous challenge because of this lack of long-term effect of treatments in the setting of advanced disease. Whereas in the setting of very early disease, we have an update that came from ESMO this year that regards adjuvant therapy that I will touch upon because that leaves hopes. So essentially here is the, it doesn't move, okay. Here is the, here are the issues we could discuss regarding this disease. In terms of prevention and early diagnosis, so far there is nothing specific and no screening test available. Nevertheless, the next talk will be devoted to this. So I will refer you to the next speaker for this. Point 3, in order of, say, the logical temporal order of events, comes the biopsy. It's a real ordeal because it is really a major issue to biopsy or not to biopsy. And I will deal with that within the next few slides. Staging is also very difficult. Whether to judge the disease as resectable or not is a problem, as we will see. And surgery is so rarely feasible as compared to other diseases. The proportion of patients who are not candidates to surgery, either because of the general condition or at presentation, or because of the dissemination of the disease, is very, very high, is at least 3/4 of the patient. Surgery is not an option at the beginning. As I anticipated, adjuvant treatment finally gets some good news and some updated good news 3 weeks ago at ESMO this year. I will mention that in the end. In terms of the palliative treatment, we do have single agents, doublets and triplets available. But again, as I emphasized in my introduction, we cannot count on long-term benefit. They always exist. It's always there, the outlier. The person who 2 years down the line is feeling well after obtaining a major response. But this is a sort of exception. And above all, it's so difficult with the advanced disease, within the advanced disease setting, to see people who are feeling well 3-4 years down the line, which is something that is happening in other diseases. And because of this, and because of the development of technology, we may have a fairly strong optimism about this happening as well in this disease, but so far we cannot say that. And finally, an issue that comes up very often, given the location of the pancreatic cancer, and that is when the patient is when a patient has become jaundiced, whether it is worth putting the stent in, that is the small tube that drains the bile fluid, sometimes is not worth it. So we are talking, you see the title, we are talking of the worst of all cancers, unfortunately. Now, in order to organize my talk, I will refer to three slides that I made out of the site that I put up for patient, and see what is specific for a pancreatic cancer patient. So the patient-dedicated site is organized in 4 different areas. Number one is, I'm afraid to have cancer. What can I do to prevent it? And again, I refer for this to the next talk. The second section is, a tumor has just been found. What is waiting for me? What shall I expect in the next few weeks? The third is, okay, things are going well. And the fourth is, things are not going well. Okay, so now let's see the peculiar problems that a patient with pancreatic cancer, suspected pancreatic cancer, has to face. A tumor has just been found. First of all, you need to be certain. Second, you need to understand how diffuse the disease is. And third, you need to understand how to begin treatment with. So first of all, this is not a minor issue, having a sure diagnosis, a certain diagnosis. Why is that a special issue for pancreatic cancer patients? Because the disease is located in an organ that is difficult to access. So, and that is the first reason. Usually, getting a biopsy is either endoscopically or percutaneously, usually provides the certainty of the disease. However, usually that takes some time, but sometimes that doesn't happen. And this is sometimes not even the biopsy provides certainty. Okay, and that is a specific issue for pancreatic cancer. I don't know if you know, but this disease is such that out of a chunk of tumor like this, 99% of the cells may be fibrous type of cells, connective type of cells, and not cancer cells. So the microenvironment is terribly important. And we think that 1% of the cells may just be cancer. So you may go in with a needle and not getting the answer. And that is the reason sometimes of frustration for these patients, because you undergo the procedure and still you don't get the answer and you're wasting time. So that's a specific issue. Sometimes a biopsy is not necessary. Now, we have this dogma that in oncology, aside from the other 4 sources to make diagnosis, that is what the patient tells you, what I find on the patient, imaging and hematology type of test. In oncology, the dogma is that you need always the biopsy to make sure. And that is actually what is recommended from guidelines. But again, getting a biopsy sometimes means wasting a lot of time. And sometimes getting the biopsy done actually triggers the pain just because of the leakage of the pancreatic enzyme. So again, in the main interest of the patient, sometimes biopsy in this disease is not necessary. Again, we had a debate within a Europe context a year and a half ago. No, that was almost 2 years ago at ESMO, where I presented these issues to 400 oncologists coming from over the world. And I asked, if you have a patient with classical symptoms, classical pain, thromboembolic diseases like phlebitis, plus a CA19-9 elevated like 10,000, and a classical pattern of metastasis, how strongly do you think you need a biopsy? And 50% of them voted as I voted, and that is, I don't get a biopsy on this guy. I treat him immediately. Again, I know that this goes against the guidelines, and we may talk about that, but that's a major issue, because if you are in an institution where within 2 days you get the biopsy done and the pathology report back, fine, that is not an issue. But in 90% of the institution, that is not the case, and you may waste the time. Now, the second issue is understanding the severity of the disease, so getting the staging done. Why is that important? Well, staging is terribly important because if the disease is localized, you may still hope for cure. Again, cure is possible in this disease, despite being the worst cancer among all others. Still, cure is possible, provided that the disease is very small. And that is why staging is so important. Unfortunately, sometimes it's very difficult to recognize the difference between the resectable condition, where I can take it out completely, and the non-resectable condition. To the extent that within the next 5 to 8 years, the new category of borderline resectable conditions have been created. And there are criteria that define this condition. The next question that comes up is the initial treatment, and that is dependent upon the stage. If the tumor is resectable, sometimes neoadjuvant therapy is implemented in several types of tumors. In pancreatic cancer, this avenue has been pursued as well, with recent trials from Germany and from the US. Nevertheless, the administration of neoadjuvant chemotherapy in a resectable condition has not really revolutionized the field. It's a preferred way to start when the disease is resectable, but that is not, if the patient goes directly to surgery, that is certainly not a mistake, meaning that that is not a step forward that is very substantial. There are no alternative to surgery in terms of radical intention, in terms of chances of cure. Say, for example, in breast cancer or non-small cell lung cancer for very localized disease, you have the alternative of radical radiation therapy. Well, that is still a possibility for pancreatic cancer, but the amount of radiation you need is so high that is actually not an option. So again, alternative to surgery is again something that is lacking in pancreatic cancer. After surgery, of course, in all the diseases, you have this phase of assessing the risk of relapse. And usually you have a balance. Say, take colon cancer, stage 2, in most cases, it's not necessary to go for adjuvant therapy because of the already very good prognosis and the very limited benefit of therapy if it is prescribed. In pancreatic cancer, the risk is always high. As a minimum is 60%. And these are the cases of R0 resection, meaning everything taken out. So again, the need for adjuvant therapy is really a must if the patient has been resected completely. A must that, of course, sometimes is not doable because of the condition of the patient, because the operation of pancreatic resection is one of the most important major ones that can be done. So yes, is adjuvant therapy a good way to prevent recurrence? I will give you the numbers. In general, with no therapy, curability of this disease is in the range of 5%. This comes from adjuvant trials. Okay, if you use one drug, this percentage goes up to 15%. With 2 drugs, it goes up to 20%. With 3 drugs, the latest report 5-year disease-free survival in the range of 30%. Again, and this is with the triplet, the French regimen. Finally, initially, the condition may be such that the disease in at least 50% of cases is advanced right from the beginning, and therefore surgery is not an option. And several people ask, how is it possible? She was well until a month ago. And now you're telling me that there is nothing to do? Well, unfortunately, that happens in every tumor, but it's extremely unusual for all other tumors, whereas it's fairly common in pancreatic cancer. So this is the type of monster we have to face. Now, when the tumor is disseminated, usually in other type of cancer, we have different degrees of severity. Sometimes the local recurrence is operable. That is not the case for pancreatic cancer. Sometimes distant metastases are operated, which is not the case for pancreatic cancer. And for pancreatic cancer, when metastases are there, they are not operable. Why? Why cannot be operated? Well, they can actually be operated, but the problem is that very soon they will disseminate in other organs, and that's the reason. So what is left for metastases that are inoperable is start first-line therapy. And after a while, we evaluate the efficacy via imaging, and sometimes therapy is working. 30% of cases of pancreatic cancer responded to chemotherapy. Unfortunately, though, what happens in other tumors, that is complete response, doesn't happen in pancreatic cancer. It's extremely rare. So most of the times, after a certain period of efficacy, we continue going on, but we reach the point when the disease progresses. And therefore, we try with second lines, but it is unusual to go to third and fourth line as in other cancers. Therefore, we fairly soon arrive at the relevance of supportive therapies only. Now, in order to conclude, again, prevention and early diagnosis, I leave it to the next speaker. How to be sure about the diagnosis? Again, guidelines must be respected, but again, this must be filtered through clinical judgment. If the patient is rapidly deteriorating, and you are not in a condition to provide the diagnosis within days, a few days, go ahead with the treatment if you are sure about the clinical condition. Staging, well, we hope in new technologies that will allow us to make the diagnosis earlier and earlier, so that the percentage of patients cured with this disease will be higher and higher. Surgery, a recommendation. It's so important that this area of surgery is one of those where the concept of high volume centers provide the best type of surgical intervention is really true. So again, this is a type of surgery that cannot be left in the hand of those who make less than 4 or 5 in such intervention per year. The adjuvant treatment provides us finally a very good hint. Now we have moved 6 times above the chances of cure that are afforded by no treatment. So with a triplet for FOLFIRINOX, we reach the plateau at 30% of those patients are radically resected. In the palliative treatment, again, we may be proud of having multiplied by 5 or 6 the median survival of patients with advanced disease, but still we need the long-term effect. And for the palliative time, when jaundice comes up, am I really doing good to patient in placing a stent or not? Use clinical judgment. Thanks very much for your attention.